about sharing our stories. So have we got you there, Kaya?
Yeah. Hi, Hannah. Thank you.
Well done.
I'm also on Darug country, so I'd like to pay my respects. The project I'm presenting on is called Sharing Our Stories of Health Research Partnerships. Initially, this project came about in the development of the Aboriginal Health and Wellbeing Clinical Academic Group. A survey and focus groups were conducted to identify our members' needs and support requirements. The focus group and survey results come back and suggested our members wanted resources and training to facilitate community engagement and strong partnerships with Indigenous communities. Can you please change the slide, Laurel? The aims for this project were to examine health research partnerships from an Indigenous perspective, to develop indicators for strong research partnerships between Indigenous organisations and research institutions, and develop a number of resources to guide researchers with health partnerships with Indigenous communities in future. Next slide, please. Methods, we did the initial survey and focus group, we did a literature review. Arnie Carey went around New South Wales pre-COVID and delivered her applied method of cultural proficiency workshop. And we filmed a yarning session with a number of community leaders and cross-cultural researchers. So that was one of our outputs. Next slide, please, which is the Partnerships in Indigenous Health film. We did a Steps to Success model of research engagement. We did a number of online modules on the social determinants of health, which affect most Indigenous communities. And Arnie Carey also filmed her applied cultural proficiency workshop. All those outputs, I believe, can be accessed on the Marajulu Bajari Gummul website. Laurel, can you please play the video?
Wish us luck, everyone, as we're swapping platforms here.
What makes a good partnership with Aboriginal communities?
Respect.
Self-reflection.
Friendship.
Consistency.
Willingness to learn.
Trust.
Trust.
Aboriginal people often say that they are the most over-researched people in the world, and you come to think, why is this the case? That's largely because a lot of the research that's been done in Aboriginal communities often hasn't met the needs of the community.
A lot of people have no idea where to start when it comes to researching Aboriginal communities or ways to do it appropriately. What makes me passionate is being able to get the information out there so that we don't have this whole flood of research continuing to happen with Aboriginal communities that doesn't need to happen.
It's the community that knows best what they need to actually best benefit them.
It's really important that for non-Aboriginal organisations or non-Aboriginal people working with Aboriginal communities, they understand the importance of pacing their engagement and taking that time. And when you're taking that time, it's really about building an understanding of the community, their history, and importantly, their strengths.
A lot of this is actually achieved through building the relationships through yarning. So yarning is quite an informal, conversation. It's not just a matter of what you say in the meeting, but rather actually what you say outside the meetings, how you are with them, getting to know them.
I need to ensure that I'm trustworthy and I'm known. It's who you deal with in communities. It's important. You always speak to the elders, then it trickle down to the other level within the community.
Respect Aboriginal leadership and to recognise that there needs to be proper governance.
Get an understanding from their perspective about what's driving their engagement and what are the outcomes we want to achieve as part of this partnership.
Working in partnership with Aboriginal communities around health, I think it's really important that we recognise that health and wellbeing is not just seen through that Western biomedical lens. It's really important to consider health in the holistic concept. So health for Aboriginal and Torres Strait Islander people is really about the physical, the social, emotional, the cultural and the spiritual health and well-being of not just the individual but the community as well.
In partnerships, it's important that leaders acknowledge that they don't know everything and they need to learn about their partners. They need to be open to new ideas, and they need to respect the perspectives of their partners.
From my perspective of a non-Aboriginal person, what makes a really good partnership is listening to the community, building relationships with the community, and having that transparency to achieve the outcomes that you want together.
I think what makes a great partnership with Aboriginal communities is having a shared idea. If we can agree on a shared problem, a shared way of looking at the solution and working together towards that solution, that's when a project is successful.
For a good partnership with the Aboriginal community, at first, listen what people want in a partnership. What do they expect in the partnership? What outcomes they want in a partnership? There's a lot of things you look at that you want to make sure that partnership are level.
I think it's really important to be clear around what the word partnership actually means and recognising that that word can mean different things for different people.
Openness,
Mutual benefit.
Time
Transparency.
And integrity.
Really, at the end of the day, it's about that mutual respect and trust.
Lovely. Thank you so much, Kaya. And I couldn't stop that little film. And for me, the main word that came out of that is trust. So what a great way to begin. I'd like to now invite Paul Sanders to give his talk on cultural proficiency in Aboriginal and Torres Strait Islander research. This is a mixed methods cross-cultural evaluation of a novel resource. Are you there, Paul?
Yes, I am.
Okay, over to you.
Great. Hi, everyone. My name is Paul Saunders. I'm a Biripi man from the north coast of New South Wales. Today is, I'm sort of glad I went after Kai because this sort of segues into my evaluation now. So as Kai mentioned, those resources were developed and they were developed really in response to the poor research outcomes that a lot of Indigenous communities suffer from, I guess. And that's because, can we go to the next slide, please, Laurel? And that's because we often try to fit a square peg within a round hole, or in this case, a square peg within an oval office. We apply Western research methodologies, and they result in unfavourable outcomes for Indigenous communities. They can result in conflict between the researcher and the community, or they can even result in intra-community conflict as well. And it often disenfranchises the community because what the community needs out of the research isn't often met. And so we need to develop a strategy where research can be inclusive, it can be equitable, and more importantly, it can be progressive. We know that research is the foundation for basically any sort of policy change. And so if you're having unfavourable outcomes within research, you're going to have unfavourable outcomes within health, within education, and that ultimately leads to unfavourable outcomes within employment and impacts on the rest of the social determinants of health as well. So if we're able to have equitable and progressive and inclusive research with Indigenous communities, then we're able to have more favourable outcomes that result in better health outcomes, better educational outcomes. So I undertook a mixed methods evaluation of the resources that Kaya was just talking about. And we did a cross-cultural approach. So we got Indigenous researchers as well as non-Indigenous researchers to evaluate them. And the technique that we used was a rating scale, but it was also, we actually undertook a SWOT analysis where we looked at the strengths of the resources, the weaknesses, the opportunities that they could provide, and also the threats as well. So we were able to ascertain really what Indigenous as well as non-Indigenous researchers thought in terms of building their cultural proficiency. And then we also had a group that undertook the workshop, which was a non-Indigenous group that undertook the workshop that Arnie Kerry runs, which is the cultural proficiency within research, or the applied cultural proficiency within research. So what we found was, what we found between the Indigenous and the non-Indigenous group is there was no real significant difference in terms of the perceived cultural proficiency between those groups. But what we found was that the non-Indigenous group that undertook the workshop showed the biggest change, and that actually undertaking a workshop and utilising that applied cultural proficiency really allowed them to change or start the process of changing their attitude and their behaviour towards how they thought about research, and utilising that Indigenous lens to be able to think about research in a different way. Oh, I've got Hannah waving at me, sorry. We'll go to the next page, please, Laurel. So ultimately, the outcome that we're looking for is equity within Indigenous research, and ensuring that non-Indigenous researchers go into a partnership with Indigenous communities, as the video explained, wanting sort of the same outcome and working towards the same solution. Thank you very much.
Thank you very much, Paul. Sorry to be waving at you. That's such important work. To try and get into 3 minutes, it's almost cruel, but we've got so many good things to hear today. So I'm just going to move on now. Now, Loretta is just still waiting for Veronica to turn up, so we might move to Christine Carriage, if that's okay with you, Christine. Hopefully you're there. We got Christine there. Hello.
Can you hear me? Sorry.
Yes. Welcome, Christine. And Christine, you're from 3, and you're going to be talking about how Aboriginal people engage and connect with Aboriginal community-controlled health organisations. Thank you.
Thank you, Hannah. Hi, everyone. My name's Chris Carriage. I am from the Yuin Nation of South Coast, but I live and reside and work and breathe in Dharawal country. Now, this is the beginning of my PhD, so I'll explain to you why I've chose this subject. And so I've been working AMSs for over 30 years, and with them through just as a director or as an employee, and just my personal involvement. I just love being there. But when you go into communities, you kind of find out exactly what they really want to think about their AMS and what that means. And so when I started looking at the literature, it came up with that most of their literature came from a clinical perspective or a disease perspective. And it wasn't about the AMS itself and what our people think about these AMSs and what they interact with. And so I started looking at their well-being of them using these AMSs. So that's how I came about. And plus I had a couple of CEOs ask me some questions that kind of sparked my interest along the way. Could you change, please, Laurel? Ding. So my research is going to it's going to document the opportunities AHOs provide for communities. You know, so I want to identify the motivators and the engagement and connection. I want to know exactly what makes them come there and do that. And I want to unpack that relationship around Aboriginal people and their AHOs, because I believe that AHOs are really, really personal services when it comes to our communities. And so these are my exploring questions. And so I just wanted to sort of look at, how and why they do the engagement with them and how and why they connect. I also want to know how that connection affects their sense of well-being and health. And because I think that when we put a health perspective first, we tend to go straight to a clinical view of it or a clinical model. But when we put a well-being first, we start to explore that well-being and what that means. And of course, I want to know if they've got a connection and how they want to strengthen that connection with their AMSs. It's about the way that they live and breathe. And so we know that AMSs come in many shapes and forms. They have a lot of services they provide, a lot of community groups, they have clinical aspects, and they have the directors. And my exploring of that will be around the directors, the staff, the Aboriginal staff within there. Why have they worked there that long? What makes them come back? And also our directors, why are they directors? Why do they put the hours in? And then also our community groups and what makes them come and do groups and work and use the service. Next one, thanks, Laurel. I'm probably going too fast. So this is the qualitative research with this case study approach. I'm also being guided by an Indigenous research methodology around that, respect, as well as was said in the first one, the way that we interact, understanding cultural knowledges, or those sort of parts of it. And I'm doing it with 2 AMSs, one situated in remote and urban, one situated in a remote community and one in an urban community, because They're very two different AMSs, and I'm not doing a comparison, but I want to see the strengths that each of these AMSs bring to their communities. And I'm coming from a grassroots perspective. I want to know about the groups. Okay, thanks. I want to know about the groups. I want to know about the people themselves. I want to know, it's like we're going to, interviews and focus groups and yarning circles. It's going to be directed with at those levels. And so, and I just wanted to say that it's about their connection, and it's about their relationship. So this is what my research is about, and actually, as I said, it comes from grassroots people. Thank you.
Thank you so much. Wave at people, but did brilliantly. Thank you.
Like you have to talk underwater. Sorry. Hold your breath.
3 minutes goes so fast. We might move on now to Chris Pitt, if that's okay. Have we got Chris there?
Yeah, I'm here, Hannah.
Lovely. And Chris is going to talk about what influence does personal culture have on organisation culture and individual leadership style. Over to you.
Great. Hi, my name's Chris Pitt. I'm a Project Officer for the Aboriginal Health Wellbeing CAG within Sphere, or Murray Darugumul. Next slide, Laurel. Basically, the aim of this project is a centre on gaining understanding of the experiences of Aboriginal and Torres Strait Islander and non-Indigenous health and research leaders and followers to develop a model of research. The study will aim to develop an Indigenous model of leadership that will be able to work both across Indigenous-led organisations and non-Indigenous organisations. Next, Laurel. The project was developed after a needs analysis conducted by the Aboriginal Health and Wellbeing CAG within Sphere. The need for a project was identified, a need for a project focused on leadership styles was identified by AMSs, land councils and community organisations. Next, Laurel. The project was refined and developed through the Aboriginal Health and Wellbeing CAG Executive within Sphere, a body that includes representation from WSU, UTS, UNSW, Sydney Children's Hospital Network, both LHDs and PHNs within our region. This led to a number of publications, next Laurel, that focused on developing and refining a model of leadership with Indigenous health-led organisations and academic environments to develop proof of concept. The work was led by Ani Carey-Doyle and piloted an aspirational model of servant leadership. Next Laurel, you can hit twice as well. The need for a project was developed through a literature review and grey literature review scan to map out the key themes. Next Laurel. So what is a project? There's 3 phases. The first phase is literature review. Next Laurel. The aim of both the review will be able to identify components that have been associated with Indigenous model of leadership, review the outcomes of Indigenous model of leadership, and evaluation of policies that influence Indigenous model of leadership. Next Laurel. And hit next a couple of times. After that, we're going to develop a model of leadership, and that'll be refined through the Aboriginal Health Wellbeing CAG Management Committee. That was chosen as an expert reference group because there's both Aboriginal and Torres Strait Islander and non-Aboriginal and Torres Strait Islander leaders in health and academics fields. From that, next Laurel, a survey will be piloted across the Sphere partner organisations and mixed other representative organisations. Next Laurel, and next Laurel, and next Laurel. And the model piloted through Lyme, CATSAM, and through Sphere, and next Laurel, and next Laurel. And the results were reviewed by an expert panel and semi-structured interviews. Next Laurel. And finally, the model we finalised. Next Laurel. What are the project outputs? Next Laurel. Firstly, it's a literature review. We identify the components of Indigenous model of leadership, evaluate the outcomes of Indigenous-led models, leadership models, and evaluation of Australian policies that facilitate Indigenous models of leadership. Next Laurel. We're going to develop a pilot model of Indigenous leadership across Indigenous and non-Indigenous organisations. Next Laurel. Results will be fed back through community, through workshops, and highlight briefing documents regarding lessons learned. And next Laurel is a guide. Next will be a policy, grey literature review guide to guide and facilitate inclusive organisational culture, recommendations regarding how to implement Indigenous leadership model. And next Laurel. And that's it. Well, thank you so much for your time. And if you need any questions, click that below email address. I can send them out to the research team. Thanks again for your time.
Okay, Hannah must be having difficulty connecting or putting her video back on, so I'll introduce our next speaker. So we're ready, we'll come back. We've got a gap in our program, but we will come back at the end. This one is Simone Nash in the School of Health Sciences. Thanks, Simone, when you're ready.
Hi, my name's Simone Nash. I am also sitting on Darug land today and want to pay my respects. So as part of my Master of Public Health dissertation, I've conducted a systematic review under the supervision of Dr. Amit Arora, looking at interventions to improve health literacy among Indigenous Australians. In April, I completed my Master's and had a baby during lockdown, so it's been a busy time. In my role as a registered nurse, I work in paediatrics, and I've noticed the ways in which lower levels of health literacy had often led to poor health outcomes for their children. I wanted to investigate what is being done to advance the health literacy of our vulnerable populations in Australia. After reviewing the literature, we found that no systematic review had yet been conducted looking at interventions being used to advance the health literacy of Australia's Aboriginal and Torres Strait Island people. The challenges facing this population are many, and the health gap still persists. Through our research, we aim to find what interventions have been used to enhance the health literacy of Indigenous Australian adults. Can I move to the next slide? Thank you. After devising inclusion and exclusion criteria, we searched 6 databases, including grey literature, for eligible studies. As detailed in this PRISMA flowchart, these searches retrieved 773 articles, of which 5 met our criteria and were eventually included in our review. Unfortunately, the studies were too diverse to allow a meta-analysis, although our study revealed some interesting findings nonetheless. I will move to the last slide, please. The majority of the studies included in our review employed some form of workshop or class in their interventions, and one included the discounting of fruits and vegetables. 4 of the 5 studies focused on improving health literacy related to lifestyle and nutrition, and 1 addressed oral health literacy. 2 studies incentivised participation, though this was not found to be very successful. Whilst all the included studies measured desirable change in at least 1 outcome measure, most suffered poor attendance and significant loss to follow-up, impacting their methodological quality. 4 of the studies reported consulting with local Indigenous communities, though only 1 offered its participants access to a translator. There was little consideration of subgroup characteristics, including language and worldview. It's not known if these factors contributed to the poor participation and heavy losses to follow-up. While it was encouraging to see some collaboration with target communities, future studies may benefit from adopting a co-design approach, allowing the tailoring of relevant interventions for specific communities. The reciprocal sharing of ideas, promotion of respect, and enhancement of participation may serve to empower communities, strengthen autonomy, and optimise health literacy among Indigenous Australians. Thank you.
Great, thank you, Simone. Hannah's unfortunately had a technical difficulty and she's dropped off, but we're down to our second last presentation in this session. So Toby, over to you, please.
My apologies, Jeanette. My computer crashed and I've just logged back in.
All yours now, Hannah.
Well, hi everyone, my name's Toby Rayburn and really appreciated the presentation so far from the Faculty of Nursing, and have a background working with Tharawal AMS and Garangara Health Service in Liverpool, and been doing some work recently around the potential of history to inform nurses' work and the work of other health professionals. And I'd particularly like to thank Auntie Kerry Doyle and Dr. Paul Saunders and my colleague Matthew James from Tharawal, who've contributed recently to this paper we've been doing, looking at the potential of knowing more about local history in the work of nurses. Could you go to the next slide, please? Yeah, that's the one. And I'd also like to acknowledge the role of my daughter, Michaela, who's an Aboriginal woman. It's played in my interest in Aboriginal health and research over the years. But one of the questions that's really fascinating to me is the question of our use of time and whether or not our conceptualization of linear time is necessarily as helpful as we sometimes imagine. And so I've just put a bunch of pictures here on one slide, and I'm trying to get at the idea of connection here across history. The picture in the top left-hand corner is a picture of a ship named the Willoughby, a British trading ship named the Willoughby, and the picture was painted in 1816. And that's the same year that British troops rode into Appin and committed a war crime known as the Appin Massacre. During the Appin Massacre, a number of people were killed, Aboriginal people, and one of them in particular was an Aboriginal man who came to be known as an Aboriginal warrior named Carnabagal. Now, that's a picture of Carnabagal's head, his skull, in the bottom left-hand part of the slide, and his skull was below deck on the Willoughby as it sat there in Sydney Cove in 1816, and it was taken back to Britain and taken to the University of Edinburgh. We've got a picture of the University of Edinburgh there too, and it was used to inform and support a false science named phrenology. And phrenology, very simple terms, suggested that you could work out the psychology or the character of a person's personality based on the shapes of the bumps in their skull. And it became enormously popular. And there's a picture there on the top right-hand corner of my slide of a man called George Combe, who wrote the fourth most popular and most influential book ever published in the 19th century. And it was called Constitution of Man. And this was as popular as books like the Bible during the 19th century. There was over 300,000 copies sold. And now George Combe wrote pretty obscene things about Carnabagal based on the shape of his skull. And I'm seeing Hannah there, so I'm going to speed up. But I'll just read you out a couple of quotes of the sorts of things that were deduced about Carnabagal based on the shape of his skull. And one of them is that the sockets of the eyes are so deep and so concave upwards that it may be presumed Carnabagal was not an adept in language. Now, this is obviously false and based on just objectification of Carnabagal's skull. But I guess the final point that I'd like to make about this is that, as I mentioned in the beginning, perhaps our linear conceptualization of time misleads us into thinking that we've come much further than we have. And what I'd like to suggest to us is that sometimes, particularly in biomedical views of mental health, we tend still to objectify people using models and ways of thinking which place too much emphasis on the physicality of people's bodies and not enough emphasis on things like social and emotional well-being. Thanks, Hannah. And so I guess the last picture there of the University of Western Sydney in the bottom right-hand corner is really a challenge to us all to do what many of the speakers have already spoken about, and that is to take some time to consider whether there may be better ways of knowing, better ways of learning, better ways of researching, and whether or not history can inform empathy among nurses and health professionals for communities of people that we work with. Thanks very much.
Thanks so much, Toby. What a different presentation, and it's always really important to be reminded of history when we have these discussions. So we're now going to jump back to Loretta Luck, and I believe Veronica hasn't been able to make it, but Loretta is going to be talking about exploring Aboriginal and Torres Strait Islander carers' experiences from sad news to sorry business. Are you okay, Loretta?
I'm okay. In advance, I know Veronica would have done, oh, I think it might be Veronica now, excuse me. Come in. Come in, you're on. Oh, no. Sorry, yes.
They're early.
Helen? Go.
Sorry, Veronica, this is a very stressful way to enter it all, isn't it?
Yeah, sorry about that.
That's okay. We're ready to go when you are.
I might have to catch my breath in between, so hold the clock. Okay, so we designed this project. We wanted to capture people's stories about sad news to sorry business in a culturally safe and appropriate way. We did this by the way of having Aboriginal people on the research team, choosing culturally safe venues to have the interviews, and we revisited people that participated. The research team was made of 7 people. 3 were Aboriginal. We partnered with Aboriginal organisations to help spread the word within the community. Sorry, I'm a bit out of breath. And okay, so we did it through the community, through Aboriginal health workers, attending Aboriginal organisations and networking. We made sure that Aboriginal researchers done the interviews alongside the researcher. We know Aboriginal people engage and trust Aboriginal people they know. So the Aboriginal researchers are connected with the community that we interviewed. The Aboriginal researchers understand cultural, what they can say, and the importance of sad news to sorry business. This is not often spoken about. We know the right terminology and the right words to use when interviewing Aboriginal people. The current Aboriginal researchers have no experience, so this is a genuine yarn up about the journey, and the interview questions we used were only as a conversation starter. There was no wrong or right answer. And the venue that was chosen for the interviews is known to the Aboriginal community as a safe place to attend. It is a place where people feel comfortable. We know that it is very important to hold these interviews face to face. For this to go ahead, we made sure that COVID precautions were practiced. Face to face was important, so we could read body language. For example, when people needed time to have a break, have a cuppa, get some fresh air, breathe, laugh or cry. We walked outside and listened and still heard their stories. The most important thing for the Aboriginal community is follow up with the transcripts. This is important to make sure that we understood what they had said, to give the person the option to either change or add anything. And it's important to follow up with these transcripts face to face to make sure people were okay, especially in the time with COVID, as a lot of people have been alone, isolated, and not being able to attend their weekly groups. This research brought up a lot of emotions. So to address this in a cultural way, we really need to check in so we knew they were okay. So that's the end of that. But it's been, people have had a lot of input into it, so it's been very well received within the community, which, yeah, it's not often spoken about.
Thank you so much, Veronica, and I'm so sorry about rushing you in at the last minute. But you did.
That's okay. Sorry I was late.
That's okay. That's no problem at all. I'm just going to now wrap up this session. I think we've run a little bit over time, so we won't do questions, but there are lots of fabulous comments in the chat box. Please interact in that, make connections, get information from each other. And I'm now going to hand over to Associate Professor David Marnes to run Theme 2 Clinical Interventions. If everybody else who's not online, who's not actually going to present, if you could turn your videos off and your mute yourself, that would be great.
Okay, well, welcome to the second session. I'd also like to acknowledge the country of the people I'm sitting on, and that's the Watama Malagal people. And to keep things moving, I've got my timer at hand. I'll turn my video on when we hit 3 minutes each time, and I'll wave around frantically if we go a little bit over. So I'd like to invite our first speaker. Oops, I can't see the screen. Sorry, just having a technical moment.
Laurel's just bringing it up at the moment, David.
Okay, fair enough. It all disappeared on me. That's okay. Beautiful.
Next, Laurel.
So it'd be Yinsi on behalf of David Simmons. and I'll leave her to introduce this herself.
Good afternoon. My name is Jinsey. I'm here to give you a quick overview of the diabetes contraception and pre-pregnancy program that has been underway in southwestern Sydney since February 2018, and our proposed plan to expand the program across Aboriginal networks. Next slide, please. The Diabetes Contraception and Pre-Pregnancy Program, also known as DCAP, targets women with type 1 and type 2 diabetes in the reproductive years. Why DCAP? Women with type 1 and or type 2 diabetes who become pregnant have an increased risk of adverse pregnancy outcomes. One major group of long-term complications are fetal malformations. Studies from Campbelltown and Liverpool hospitals showed malformation rates of 7 to 12% among women with diabetes compared to the background rate of 2%, costing on average $1 million per major malformation. Aboriginal women are at high risk for type 2 diabetes, and babies born to these women are likely to experience poor outcomes of pregnancy than babies of other Australian women. In 2018, there were 4,200 babies born to Aboriginal mothers in New South Wales, and 1.2% of these pregnancies were affected by pregestational diabetes. The rate of congenital conditions among babies born to Aboriginal mothers was 20 per thousand, compared with 16 per thousand for babies born to non-Aboriginal mothers. The objective of DCAP program is to increase the awareness of unplanned pregnancy risk and proper actions to plan for wanted or unwanted pregnancies. The overall aim of DCAP is to decrease the high rates of congenital malformation and other adverse pregnancy outcomes. Next slide, please. The Diabetes, Obesity, Metabolic Disease Clinical Academic Group is now leading a translational research grant scheme application in partnership with 7 other LHDs and Baptist Hospital to implement DCAP across multiple districts in New South Wales. This slide shows COMBI behavioral change framework to the development of the NSW DCAP intervention. The outer rim of the implementation science wheel indicates strategies from published interventions to reduce malformations and adverse pregnancy outcomes or unplanned pregnancies. The gray rim shows components and outcomes of the Southwestern Sydney DCAP pilot. Implementation of DCAP in Southwestern Sydney resulted in an increased uptake of effective contraception, reduction in pregnancy rates, and increased referrals to a pre-pregnancy clinic. The inner rim shows planned components of the NSW DCAP program. Next slide, please. We'll be expanding the program across Aboriginal networks in collaboration with Aboriginal Health and Wellbeing Clinical Academic Group, led by Professor Andy Kerry-Doyle. Her team will support DCAP rollout among the Aboriginal populations within each district. We are working with Taraval Aboriginal Medical Service. They are mailing out letter packs to women from Aboriginal background regarding pre-pregnancy care and contraception advice. NSW DCAP is the first Australian diabetes pre-pregnancy and contraception study involving substantial Aboriginal population. Thank you very much.
Okay, thank you. That was spot on time. We'll jump straight to Milan, who's the next speaker. He'll be evaluating or speaking on the evaluation of diabetes screening in Aboriginal Australians using random glucose and hemoglobin 1AC in Campbelltown Hospital.
Hi everyone, thank you for giving me this opportunity to speak. I'm presenting on behalf of my collaborators and co-authors and the funder, the New South Wales Agency for Clinical Innovation. And I'd particularly like to thank the Southwestern Sydney Local Health District Aboriginal Chronic Care Team, who've been very helpful in conducting this study. Next, please. Laurel, next. Thank you. So we know that 1.7 million people in Australia have diabetes, and 500,000 people are walking around unaware that they already have diabetes. So we also know that Aboriginal people are 4 times more likely to have diabetes, and chronic diseases, of which diabetes is a major contributor, makes up about 70% of the health gap. Next slide, please. So we set out to screen everyone who identified as Aboriginal and was an adult who came to Campbelltown Emergency Department and had a routine blood test over a 3-month period earlier this year. Of the 19,000 plus attendances, we found that 6.2% identified themselves as Aboriginal, When we excluded children under 18 years and also people who were admitted more than once in this period, we ended up with 350 people who had a blood sample done. And 13% of them already had pre-existing diabetes. On the blood sample that they had already done, we added on an HbA1c in the lab later, and everyone except one patient actually had a random blood glucose done as part of their clinical care. We found the mean age to be 37 years and 2/3 of the attendees were women. Next, please. So of the 305 people that were not known to have diabetes, if you look at the top row in black, so the 3.9% of these people actually met the clinical criteria for, or the biochemical criteria for diagnosing new diabetes. What this means though is that although because of the long-term implications of diabetes, we would usually need at least 2 blood samples or 2 readings in that range to actually diagnose people with diabetes. So we would normally ask them to go to their GP and have a repeat test. We found that if we lowered the cutoff and used the pre-diabetes range of 6 to 6.4% HbA1c or random glucose over 7, we found that 1 in 6 people or 16% had an abnormal test. And if we lowered the random glucose even more to 6.1, we actually found that 1 in 3 people would have an abnormal test. What we think is that a lot of these people would probably not actually have diabetes, but they may have pre-diabetes or be at high risk of diabetes. Next, please. Next, Laurel. So what we found was that the opportunistic screening of people who are already having blood samples done, the pickup rate wasn't as much as we expected based on data from Blacktown and other areas. And when we looked at just using random glucose and not the HbA1c, we found that if we used a cutoff of 7, we'd have missed 3% of the like the high HbA1cs. And if we'd used the cutoff of 6.1, we'd have actually only missed 1% of the HbA1c. And given that the HbA1c costs an extra $10 to $15 per sample, and the results only come back the next day, we didn't think it was a very effective method of screening for diabetes in the emergency department. And we would recommend just using a random glucose. Thank you very much.
All right, thank you, Mala. We'll jump straight to the next speaker. Looking at the crosstalk between gut biota and Australian native fruits and its relevance in the prevention and treatment of type 2 diabetes in Australian and Torres Strait Islanders.
Hi, David. Hi, everyone. I am actually not able to start my video. It's showing the host has stopped it. Is there any way I can start? Okay. Sorry. Yeah. Okay. Hello, everyone. My name is Deep. I would like to begin my presentation by acknowledging the traditional custodians of the lands on which we meet today and pay my respects to their elders past and present. I also extend my respect to Aboriginal and Torres Strait Islander peoples here today. In this presentation, I would actually like to talk about how we can use Australian native fruits to prevent and treat type 2 diabetes in Aboriginal and Torres Strait Islanders. This project is currently under review by NHMRC as an ideas grant proposal. Next slide, please. So as Milan mentioned, and also as per Diabetes Australia, Indigenous people are 4 times more likely to have type 2 diabetes, that too at a younger age compared to non-Indigenous Australians. This can be attributed to the change in lifestyle, and which is more westernized now, a diet that is rich in sugar and fat and consumption of alcohol. And this all together actually contribute to a life expectancy gap of 10 years between Indigenous and non-Indigenous peoples of Australia. So what can we do about it? We think that Australian native fruits might be the answer. These fruits are a part of Australian bush medicine and Indigenous foods for thousands of years. Recently, several studies have actually shown that these fruits have anti-diabetic properties in lab conditions. But none of these studies have looked into their interactions with gut microbiota, specifically in indigenous Australians. So this is where our proposal comes in. By now, we all know that gut microbiota, a balanced gut microbiota, is crucial to maintain our health and well-being. And we also know that an imbalance in gut microbiota can lead to several diseases, including diabetes. So we want to use modern microbiology and molecular biology techniques. And we want to see how these Australian native fruits, for example, Davidson plum, will interact with the gut microbiota of Aboriginal and Torres Strait Islander participants, and how these interactions can be actually used or translate to define therapeutic and preventative strategies for type 2 diabetes. We are interested whether these fruits are able to balance establish a balance between the good and the bad bacteria in the gut. Next slide, please. So in summary, we actually want to combine the indigenous wisdom with modern scientific knowledge to improve the health outcome of indigenous Australians. So please watch this space. And in the meantime, don't forget to follow your gut. Thank you.
Okay, thank you. Now, on to our next speaker with a very simple and straightforward title, Bush Medicine. So.
I would like to respectfully acknowledge and pay my respects to the traditional owners of all the lands from where we gather to meet today, to the people of the Dharawal Nation where our work and research is situated, and particular acknowledgement to Auntie Fran Bodkin, whose vision for bush medicine guides, inspires and motivates our work. Uniquely Australian, bush medicine has been practiced in Australia for over 60,000 years. However, despite this, the role of bush medicine has been largely overlooked and undervalued, including as a recognised complementary medicine. Associate Professor Ilse Bligner and myself therefore asked the question, to what extent is bush medicine included in complementary medicine research? We conducted a scoping review adapting PRISMA guidelines and focused on the use of bush medicine in Australian populations. Although still a manuscript, we found that from the over 9,000 articles and records reporting the use and practice of complementary and alternative medicine in Australia, only 0.17% of these records reported bush medicine use or even included bush medicine in their survey questions. These results indicated that we researchers have not recognised in our research bush medicine as part of Indigenous health systems and ways of healing. Our team of bush medicine researchers recognise bush medicine as a source of health and well-being for Aboriginal and Torres Strait Islander peoples. Central to all this is Auntie Fran Bodkin, who, as a proud Bidjigal woman, Dharawal knowledge custodian and ethnobotanist, envisioned bush medicine being grown on country, researched by universities and used as a source of treatment in hospital. Collaborations with Western Sydney University have resulted in vitro and chemical characterization studies, as well as opportunities for students to learn about medicinally significant bush medicines, but also learn about Aboriginal culture, history and associations, and how these connections are equally as important to Aboriginal health and well-being. As Auntie Fran describes, science is made up of 4 parts. The white man's part, which is made up of experimentation and measurement, and Aboriginal part, observation and experience. And if you put those 2 parts together, you get the continuation of science of knowledge. What we hope, NICM 3 and the School of Medicine Bush Medicine Working Group, is that we can bring the white man's part to complement bush medicine's use and practice. Furthermore, we researchers need to negotiate agreements in regards to the rights and access to Aboriginal and Torres Strait Islander people's existing intellectual and cultural property, and also agreements to protect the ownership of intellectual and cultural property created through research. By combining all of these areas, bush medicine will continue to transcend time and place and promote better health outcomes and sustainable positive impact for Aboriginal and Torres Strait Islander peoples. Thank you.
Thank you. We'll circulate the slides afterwards. They seem to drop in and out. And we'll move on to the next speaker, which is an example of this. With Madhuri Venugala looking at the anti-inflammatory compounds identified from Synocarpia glomerulifera and investigation of their signaling pathways.
Thanks, David. Hello all, I'm Madhuri Venugala, final year of PhD student from School of Medicine. Next slide, please, Laura. This is part of my PhD research project done under Dr. Professor Gerald Munch. Here I'm presenting the anti-inflammatory effect of compounds isolated from and identified from Synocarpia glomerulifera. Chronic and persistent inflammation leads to many diseases in elders such as Alzheimer's disease and Parkinson's disease, Huntington, and many other neuropsychiatric disorders. One of the as mentioned by Beatrice in the previous presentation, one of the Nickham Bush Medicine Group's project is to discover the novel anti-inflammatory compounds. In the quest of that, we investigated the following plant for the anti-inflammatory property. This Synocarpia glomerulifera was used by Dharawal people to heal sores and ulcers. This was stated in Dharawal Pharmacopoeia written by the Dharawal Aboriginal elder and botanist Mrs. Frances Bodkin. 4 active inflammatory compounds were isolated and identified from this plant. They are tetracarbon C, B, and sideroxine and limoflone. Next slide, please. Laurel, you can press couple of, you can hit like for the whole pathway. Here I'm briefly presenting pro-inflammatory TLR4 pathways activated by LPS and IFN gamma. TLR4 induces downstream signaling via 2 pathways, the mediated dependent and the mediated independent pathways. In the mediated dependent pathways, mediate along with the other 2 proteins activate the 3 kinases, which are the IKK, PI3K, and MKK. The I-kappa kinase phosphorylates the IKB alpha, causing the dissociation of the complex, which further activates the NF-kappa B, and that translocates into the nucleus, binding to the DNA and inducing the expression of pro-inflammatory genes. Similarly, MKK undergoes phosphorylation and acts via main 3 kinases, which are P38, ERK, and JNK, as you can see in the slide. They further transcribe the C-John and C-Phos of AP1 translocation factor. It translocates into the nucleus and again binds into the DNA inducing the genes. And in the mediated independent pathway, IFN beta is produced, which along with the externally added IFN gamma activates the STAT pathway, further activating the phosphorylation of, causing the phosphorylation of STAT1 and STAT3, which again translocates into the nucleus, transcribing the detrimental genes. Here, we are investigating the effects of Synocarpia glomerulifera on the phosphorylation of ERK, C-John, and then STAT1 and STAT3, and also the phosphorylation of NF-kappa B, which you'll be seeing in the next slide. Next slide, please. Laura, thank you. Here, as you can see, the compound 1, which is tetracarbon C, has completely inhibited the phosphorylation of ERK and C-John. So is the sideroxine, and the rest of the 2 compounds, which is tetracarbon and B, significantly inhibited the phosphorylation of phospho, ERK, and C-John. Moving on to the translocation of P65, tetracarbon C has completely limited the translocation of P65, and the rest of the 3 compounds inhibited the translocation significantly. Next slide, please. So here we can see all the molecular targets that these Synocarpia compounds have exerted their effect on by downregulating the phosphorylation of ERK, JNK, C-John. Sorry, it didn't downregulate the JNK, but they did downregulate the phosphorylation of STAT3 and STAT1 as well, and also the translocation of NF-kappa B, proving them as the effective novel anti-inflammatory compounds. Thank you.
Okay, thank you. Showing a Bush Medicine Week reaching deep into a cytokine storm. Okay. All right, we'll move on to Penny Abbott, who'll be speaking on behalf of the Watch and Inflate teams.
Hello, everyone. Yeah, thank you for this great opportunity. So just presenting some of the process evaluation on the 2 trials that we're doing into ear health in Aboriginal and Torres Strait Islander children. There's a photo there of Sissy, our research officer in our Aboriginal Health Service in Brisbane undertaking one of our study visits. I'll just move on to the next slide. Thanks, Laurel. So we are working across these, across multiple Aboriginal medical services, and the map just shows our current AMSs that we're working with. The Watch and Inflate trial are clinical trials looking at management options for otitis media, which, as you would know, is inflammation of the middle ear. One's looking at acute infections, and the other one's looking at chronic infection, chronic inflammation. And they've been going for a while now, and right now we're doing an analysis on some of the interviews we've been holding with parents, carers in the study, and the research officers in our AMS and various AMS staff, GPs and nurses and audiologists, as well as all of meeting minutes to look at the implementation of the study so we can understand, you know, better ways to do clinical trial research in Aboriginal medical services, and also, you know, to inform our ongoing work. We work with a large team, and that's just some of the people down there, our network with many other people in all of the AMSs that we've been working with, contributing, and, you know, certainly like to acknowledge all the Aboriginal communities that we've been working with. There's a photo of Letitia, our AMS research officer in Gold Coast, doing some screening of children's ears at a health promotion day. So next slide. So some of our findings, you know, we've many findings. I'm just choosing a few here, but I think it's a very positive thing to undertake clinical trial research in Aboriginal medical services. In the process evaluation, it suggests that it really increases confidence that research will be of benefit and it will also be done well. The research questions considered very important. So priority health issues increase the acceptability of the study, and also with a preference to research that's actually trialling new things and not describing problems. The appropriate resourcing, obviously, is a very important thing, and it's easy to say and it's harder to do, and something you need to be reflecting on throughout the entire trial. There is a tension between the big picture of long-term research capacity building and relationships, and the need to drive a recruitment in a clinical trial, and a lot of work and reflection is to go into that. A very important part of the work we're doing has been that capacity building, the workforce development, particularly in terms of ear health. And I guess not only are we doing research, but we're providing resources, equipment, manpower, and expertise to drive some improvements in ear health. That's probably, well, definitely the most valued thing. But research capacity building is also seen as worthwhile and multi-directional. Obviously, it's not a case of us pouring research expertise into the Aboriginal medical service. It's actually, if anything, the other way. So we all need to work together. And the Aboriginal medical service-based research officers are one of our most important resources, which was definitely valued and needs support. And that's a lovely photo of some of the children at Tharawal AMS who are helping us make this photo, help us fix our ears. Thank you.
All right, thank you for sharing the successes of the team and the work that's going on. Okay, so we now move on to our final speaker, Liz Norsa, and sort of reflecting on the Southwest Sydney LHD Aboriginal Transfer of Care Evaluation using an Aboriginal and Torres Strait Islander quality appraisal tool.
Thanks, David. So actually, we're a bit different from the other presentations of this theme because we're looking at how good Aboriginal health research is done within the context of a clinical intervention, so not the clinical intervention itself. Next slide, Laurel. Thank you. So Aboriginal transfer of care model ensures that Aboriginal patients with chronic conditions can safely leave the hospital and transition back to the community. The mixed methods evaluation was funded by the New South Wales Health Translational Research Grant Scheme and was conducted by South West Sydney LHD, New South Wales South, and us from Western Sydney University. So the research team had planned to get together early this year to reflect on the research process, particularly the qualitative component, but it wasn't possible due to COVID. So instead, I spoke with the research team individually, and we used the Aboriginal Torres Strait Islander Equality Appraisal tool to help guide our discussion. So this tool was recently published in the BMC Medical Research Methodology Journal, and the NHMRC Create Methods Group at SAMRI rigorously developed this tool that incorporates Indigenous values and principles. It consists of 14 questions designed to review research literature from an Indigenous health perspective. It could be used to when planning your research, and it also could be used for post-hoc project reflection, which is what we did. Some of the question examples are, did the research respond to a need or priority determined by the community? Did the research have Aboriginal and Torres Strait Islander research leadership? Did the research have Aboriginal and Torres Strait Islander governance? Did it demonstrate capacity strengthening for Aboriginal and Torres Strait Islander individuals? And did everyone involved in the research have opportunities to learn from each other? Next slide, please, Lorelle. Thank you. So I found the tool easy to use. The companion document was very helpful. The 4 response categories of yes, no, partial, and unclear made us think deeper about our responses, and it showed where our strengths and weaknesses were. There were new insights that we found about what we did and what we'd learnt from each other during the research process. For example, our colleagues' perspective on building health research capacity within their team, and how the collaboration between service providers and researchers worked. So I would recommend all of you check out the tool. It can be found at their website, which is on the link there. And I'd also like to acknowledge other research team members for their contribution, because in particular those who were responsible for delivering the model and also made a significant contribution to building this evidence base. So thank you.
Thank you. I want to thank all the speakers for a series of talks that showed the depth of work that's actually been led by Western. It's astounding each time you see it. The depth of work, its expanse over the state, and its reflection on how it's delivered. They are remarkable aspects that should be commended. I now have the pleasure of handing over to our final chair for the final session. So I'm done. Thank you.
Thanks, David. And hello, everybody. My name is Karen Liu from School of Science and Health. And I'd like to begin by paying my respect to the local Indigenous people and the traditional custodians of the land where we are meeting upon today. And without further ado, I'd like to introduce our first speaker in this final theme, workforce services and training. And so can I introduce Rachel Gregory Wilson, presenting on the topic, closing the gap, reducing infant mortality. Rachel, please.
Thank you. Hi everyone, it's been great to have the opportunity to listen to all the presentations beforehand, so thank you. This research project has evolved from both my PhD project, where I'm undertaking to explore how courts make decisions related to foster care and the impact this can have on Aboriginal infants, and my previous clinical experience in working with Indigenous communities all across New South Wales in child and family health. This research project is designed to make a difference in health outcomes for Indigenous children and the rates of child mortality. And this is important because, as you can see on the next PowerPoint slide, thanks Laurel, child mortality in Indigenous communities has not improved at the same rate as child mortality in non-Indigenous communities, according to the 2020 Closing the Gap report. In 2018, there were 117 Indigenous child deaths, and this was equivalent to a rate of 141 per 100,000, which is twice the rate for non-Indigenous children. And this was not within the range required to meet the target. And most Indigenous child deaths, 85%, occur in the first year of life. So a solution, next slide, thanks Laurel. Research has shown that Aboriginal and Torres Strait Islander people have called for an approach to family and child health that values their experience and is strength-based. With this in mind, even though this project is only just beginning and we are looking forward to successful funding of an Indigenous scholarship and seeing what difference a scholarship recipient can make, we are looking forward to keeping you all updated with the progress of the project. And I'd like to acknowledge Karatani and Diana Jeffries, who is also working on this. Thank you.
Thanks, Rachel. Very good timing, a very important research. Thank you. So now I'd like to invite our another speaker, Robert Doyle, to present a topic on the why analysis applies cultural proficiency in the health system. Robert, please.
Yeah, hi. So Laurel, just pretend you play Candy Crush and just hammer the button the whole way through. I'm gonna go quick. Is my thing up? Yes, it is. Thank you. All right. Sorry, just bringing up my stuff. Okay, hi. I'm Rob. Winninini people, but brought up on Darkinjung land. And just going to show you a little bit of research that we did in Geraldton around health services, and that was at their request. The local library as well asked the uni to have a look into this. So we found that first impressions last. When Indigenous people first attend any health service, we look to see if we'll be welcomed and affirmed. And we use a simple why analysis. So the why analysis is what an Indigenous person sees, hears and feels when they attend a health service. This snapshot evaluation can be translated into practice as seeing what is in the clinical environment, feeling safe with clinicians and staff that are culturally competent, and hearing consultations with clinicians and staff that leave us feeling valued and affirmed. For example, while this poster, sorry, I'm popping two things up at once. So we're up to the next poster. Can we scroll over next slide? Thank you very much. So for example, while this poster is correct, just keep tapping away for me, please, Laurel, and the information is important, it might look confronting for some Indigenous people. It doesn't look Indigenous, and it won't attract the attention of the people you need to reach. The second poster looks inviting for Indigenous people, and we are more likely to have a conversation about a sensitive issue. If we can move over to the next. In this example, we've got the receptionist. Sorry, thank you, we do. In this example, the receptionist, she looks a little scary, and Indigenous people might be reluctant to approach, and we've got to remember the long echo of institutionalized racism means that it takes a lot of extra courage for an Indigenous person to ask for help. And when you look at the second picture, you just got to pretend you've got cataracts. It's a little bit bad resolution, but Indigenous people these people welcome you to the service. They do it without judgment. They do it without shame, and we would be happy to use this service. Moving on. Indigenous people know when we are welcomed and when we feel culturally safe. We present later and sicker, and it is often because of institutionalized racism and unconscious bias. It takes a little bit of effort on the part of service providers to ensure that an environment is welcoming and affirming. And if we get it right for black fellas, we can get it right for all Australians. So it's really simple. Just going on the why analysis again. First impressions last. Indigenous people often rely on word of mouth, and a culturally unsafe environment just won't get you many likes on your Facebook page. That's it. Thanks for having me.
Okay, thanks, Robert. Again, very good timing. Thanks so much. We'll jump straight into the next presenter, Philip Gold. And the presentation topic is Children as Health Ambassadors, an approach to improving health, well-being and learning outcomes for Indigenous children and communities. Philip?
Sally.
Oh, sorry. Yeah, I got it wrong. Yeah, Philip is presenting next. We have Sally presenting now with the topic of inequalities versus inequalities, children's transformation and empowerment in Indigenous health education. Apologies, Sally and Philip. Sally, please.
Thank you. You're welcome. Good afternoon, everybody. I join you here today from a high ridgetop on Bidjigal country. I acknowledge we're meeting on the unceded territories of Aboriginal people. I acknowledge my workplace supervisor, Auntie Kerry Doyle, and elders past and present. This slide shows the amazing team supporting me on my research journey. Also walking beside me is my amazing family scattered the length and breadth of Australia. Half a lifetime ago, as a non-Aboriginal woman, I had a transformative encounter with Australia's history. I helped document the Aboriginal Memorial now in Canberra. This history was missing from my education and I was mad. I started researching. Around 91, I met Doreen Eates. Police had shot dead her partner at home in his bed. I'd heard about deaths in custody, but until then, I didn't get it. In 95, 3 elders came to my home in Redfern. They'd been at a hearing for bringing them home. I'd heard about kids being removed, but again, I didn't really get it. In 96, I met Elaine Telford and Lisa Jackson-Pulver, who you know. We made a film to stimulate dialogue in the community. Get a degree, Lisa said. Come and work with me. Education is the only way we have of making a change. In education, we call the process of making meaning that really shifts your point of view transformative learning. Next slide, please. It's talked about a lot in Indigenous health space. My questions are focused around what changes in students who complete postgraduate education in Indigenous health. At Murray at New South Wales Uni, we developed 2 electives for MPH students, Aboriginal Perspectives of Public Health, and another one focused on social and emotional wellbeing. We used scenario planning in the first one, and in the second one, a 3-day immersion program in their Aboriginal Family Wellbeing Empowerment Program. We evaluated the courses as we went. Pre and post-course surveys were taken with the growth and empowerment measure. This was derived from the experiences of Aboriginal participants in family wellbeing in 2010, and so we administered it to consenting participants at the start and finish of each of our courses over the 6 years. We also collected their online talk, what the asynchronous online discussions are. We hope that these would help us to explain how any change we might observe with the GEM might be taking place. Next slide, please. So 147 participants have participated and wellbeing was shown to enhance in both courses. However, the students in the lifespan course, the ones that did family wellbeing, started at a lower base and grew more. In the middle, you can see the sensitising concepts I've been using to analyse their online talk by attempting to hear what their text is saying. Each case is distinctive in the way students have felt and worked through their emotional responses to the course content, which includes history. In perspectives, growth unfolds, and their voice talking with each other grows. They cast off deficits models, critique, advocate. They feel valued and safe and connected. There are 3 meta themes about history is the first one, which includes concepts of time, about relationships and space, especially social distance, and about practice changed. Within each, a collective story of movement comes from disorientation to action. They speak frankly, they test new knowing and doing in their homes and workplaces. 3 meta themes also occurred in lifespan, delving deeply, learning by doing, and integrating theory. They felt really uplifted and renewed by the workshop. New concepts such as basic human needs and relationship triangles rolled around in their heads for days afterwards. They cycle through critiques of power. They worry about structures. There's growing discernment, new lenses, and a real true appreciation of holism. The value in having time to reflect and work through disorientation was very evident in both courses. Understanding these pathways to change among older professionals is hugely important to our work as health educators. Education work that must be scaled up to include the professional development space, to build a culture that is self-aware, to make spaces in health safer, so needed according to my colleagues in the Career Pathways project released just this last week, to change how health business is done. Now more than ever, as we enter a new paradigm led by strong Aboriginal health leaders. Having a voice is not just a slogan. It can mean the difference between life and death. Thank you for listening.
Thanks, Sally. A great project. Thank you. So now we'll have Philip Gold presenting a topic on children as health ambassadors, an approach to improving health, well-being and learning outcomes for Indigenous children and community. Philip, please.
Hello, everyone. Firstly, I'd like to acknowledge the saltwater people of Krugai, whose land I live and work on. In a 2020 Australian Government Closing the Gap report states there's much more work to be done to close the gap in health inequality. And this should include harnessing the strength of Aboriginal culture as an underlying determinant through to good health through identity and belonging. My research will examine the practice of engaging young Aboriginal boys and girls as doctors. Now, this has been a part of Aboriginal culture for tens of thousands of years. Therefore, I'm focused on capturing the experiences of children who have participated in a program that blends traditional medicine, traditional ways, many have been mentioned earlier, with modern medicine. Importantly, the children's voice of their experience is what I'm interested in. Included in the research will be an examination of a program called Young Doctors for Life, which is an Aboriginal led, co-designed health program for children aged between 9 and 12 years of age. The program aims to promote a change process in awareness, self-awareness, in self-care among Aboriginal children, primary school age. So some of the things that we examined in my research will be culture and wellbeing, leadership, nutrition, environmental health, hygiene, health literacy, understanding the basic health information and the importance of engaging with health services and medical services. I've forgot to say slide 2. Could you go to slide 3? Thanks, Laura. Thank you. Research findings from this study will inform future community-led intervention programs that aim to improve the health outcomes of young children, Aboriginal children. Importantly, the research findings will inform other similar programs or approaches. However, the thing that means a lot to me is I'll be listening to the children's voices, the research, also the children's parents, as well as the children's school teachers who know these kids quite intimately. And also, finally, the views of the Aboriginal program leaders who are Aboriginal and teach often in the local dialect, but definitely teach according to Aboriginal law. Thank you very much.
Thank you. Thanks, Philip. So on to our next speaker, Janine Bailey, on the topic career pathways for the Aboriginal and Torres Strait Islander health workforce. Janine or Jamie, please.
Thanks, Karen, and hi, everyone. So today I'm talking to you about a project that's recently been completed, examining career pathways for the Aboriginal and Torres Strait Islander health workforce. This was a large national project funded by the Loicha Institute. Being a large national project, there was obviously a very large team involved in delivering the projects and the different components involved in the project. And I've got the list of the team members on slide number 2. If we could skip to slide number 2. Thanks. You might recognise some of the names, and I'll give a shout out to some of the team members who are on the line today. But as I said, it was a big team involved from many different organisations across the country to deliver this project. From our end, at the New South Wales end and the Western Sydney and Western New South Wales end, the project grew from the ground for us from Mr. Jamie Newman from Billamuji, who came to us with the question asking what can they do as entities to improve career pathways for the Aboriginal and Torres Strait Islander health workforce. Now, I had hoped at this point to be able to hand over to Jamie to present the rest of the talk, but he's unfortunately been caught up in the clinic, so I'll power on behalf of the team. The aim of the project overall was to provide insights and guidance to enhance the capacity of the health system to retain and support the development and careers of Aboriginal and Torres Strait Islander people in the health workforce. There were a number of different project components. We had a literature review and secondary data analysis. Stakeholder consultations were conducted. There was a national workforce survey, as well as career trajectory interviews conducted with individuals within the workforce, and also locally situated case studies involving focus groups and interviews. And they were conducted both in New South Wales and in the Northern Territory. And if we skip to slide number 3, because we've got such a short time to speak, we won't really go through the findings, but lots of great findings were to be had. The final report from the project launched just recently on the 9th of August, and that was to coincide with the United Nations International Day of the World's Indigenous Peoples. And the project outputs are available on the Lowitja website. There's the national report and the links shown there, as well as a link to access all of the component reports from the project. But if you don't have time to write those lengthy links down, if you just Google Lowitja and Career Pathways Project, it comes up straight away. Thank you.
Thanks, it's a lot of work. Thanks, Janet. And so introducing our next speaker, Ariana Kwong and Ayish George on presenting a topic, growing up mums and pops, developing a culturally safe model of care to promote oral health among Aboriginal women during pregnancy.
Thank you, Karen. Hi, everyone. So this project is being led by PhD student Ariana Kong, and I'm here just to provide you a bit of background. So pregnant women are prone to having poorer health, and we know that it's been linked to adverse pregnancy and infant outcomes. Unfortunately, there's a lack of awareness among pregnant women about the importance of oral health. And in Australia, only a third of women actually see a dentist, even if they have a problem. Adding to this is the fact that oral health is rarely discussed by antenatal care providers, mainly due to their lack of knowledge and resources in this area. So we've tried to address this gap by developing the Midwifery-Initiated Oral Health Program, or the MIO program, which basically trains midwives to provide oral health education, simple risk assessment, and dental referrals to pregnant women. So we've evaluated this program extensively, and we found that it can improve the knowledge and confidence of midwives to promote oral health. And this also gets translated into improved oral health outcomes, quality of life, knowledge, and uptake of dental services of pregnant women. This has also been found to be cost effective and has been rolled out into policy and practice across the country, making a positive impact on pregnant women. Next slide, please, and I'll hand over to Ariana.
One of the main issues with the MIO program was that it wasn't developed with Aboriginal women or communities to ensure that it was culturally safe. So this was really the premise of this project. And what we wanted to do was adapt this existing model with the community to ensure that it would be appropriate for women. So really it was around developing a culturally appropriate model of care to promote oral health among Aboriginal pregnant women by capacity building Aboriginal health staff to promote oral health. So the Aboriginal health staff that we worked with were from the Southwestern Sydney and Greater Western Sydney areas, involving Aboriginal health workers and family partnership workers. So in terms of our study design, we really were guided by the Aboriginal community to conduct some literature reviews to see whether there are any existing models of care out there and to see what were the perspectives or experiences of Aboriginal women internationally. But in terms of a local context, we wanted to explore this a bit more. And so we did some focus groups with the Aboriginal Health staff and with Aboriginal women to explore what were some of the challenges, what did they want, what were their needs, and whether this, you know, how could we develop something with them to make something that would be effective for the community. So phases 1 and 2 informed phase 3, which I'm now up to my PhD, and I'll discuss a little bit. Next slide, please. So the elements of the Grindin Up Mums and Buds model of care have really 3 main aspects to it. The first one is that we want to integrate oral health into whatever antenatal care model maybe the service was undertaking and build upon the strengths of the Aboriginal antenatal workforce. The second aspect was around building capacity, and this came out a lot during our second phase of the Aboriginal antenatal care staff. So providing training in oral health care, and also creating resources together with them that would actually support them, provide the certification. And finally, the last aspect was how can we actually strengthen dental services to make sure that they were more culturally safe. So this was really working together with the health services here in Southwestern Sydney. So the 3 main aspects related to this was making sure that the Aboriginal health staff would know through training the existing pathways to dental services that are out there. And then secondly, working together with dental services to actually create options where an Aboriginal person could access the dental service through contacting an Aboriginal person and having an Aboriginal person there present at the dental service. And then finally, enhancing the role of the Aboriginal health staff to help where needed, make appointments to the dentist, and also to help provide reminders. Thank you.
Okay, thanks, Ariana and Aish. Very important projects. Thank you. And here I'd like to introduce our final speaker, Kayla Sale, and I'll let Kayla introduce this very important topic of the presentation. Kayla, please.
Everyone, my name is Kayla. I'm a Wiradjuri woman from Wellington Peak Hill area, and today I'm going to be discussing a project led by Professor Arnie Carey-Doyle. It's called Kitty Kana at Home. So Kitty Kana at Home, or Be Happy at Home, it came about, as we all know, with the pandemic happening, led to the closure of universities. We all began to work from home. We also couldn't go to the gym, and all of the exercise facilities were closed. So the Aboriginal health team in Southwest Sydney Local Health District asked about the opportunity of starting a culturally appropriate online exercise program that people would be able to access. So the program ran for 8 weeks. Classes were held every Monday, Wednesday and Friday over Zoom and were led by a qualified trainer named Coach Mark. So Kitty Kana at Home was promoted via a flyer through the 14 Sphere or Marriedul Bajari Gumul partner organisations, including UNSW, UTS, South East Sydney Local Health District. It was also promoted through the School of Medicine at WSU, WSU School of Health Sciences, the Translational Health Research Institute, which is where we are located, and then the Badnami Centre for Indigenous Education, as well as Southwest Sydney Local Health District through the Aboriginal Health Team. So some of our results, we had 83 people register for the program. 87% of the people who used the program used it as a way to cope through the pandemic with their mental well-being. The same amount of people found the program easy to register and access. 98% of the participants enjoyed the program and wanted to continue using an online workout service. And then 100% of the participants felt motivated by Coach Mark. So this evaluation was done through a survey once the program was done so that we could see whether or not people enjoyed it. So here are some testimonials that we found from the evaluation that we thought were good. So I loved everything about the program. I liked how easy it was to access, and Mark's coaching style gave me an opportunity to be away, gave me an opportunity to be able to take virtual group classes. I enjoy group classes as they keep me motivated. It keeps me mentally and physically healthier as I'm working from home most of the time. I'm not very fit, and as this class is virtual. Thank you for opening this platform for people of colour all around the world. I am obese but feel motivated to attend all the sessions I registered for. So we had really good feedback. Some other feedback that we had was around feeling a lot of shame going to a gym or exercising. We were still obviously allowed to exercise in parks and things like that, but people weren't comfortable with that. So most of the feedback was around feeling comfortable at home and with Coach Mark. So that was Kitty Corner at home, and we're going to be doing another session of it. So if you'd like some more information, please contact Chris.
Hey, thanks, Kayla. Fabulous presentations, and this ends all of our presentations today. And again, I encourage you to make contacts with the speakers for further discussions. We've got a range of projects addressing the needs of infants, mothers, children, students, and different generations. So thanks, everyone. And I'd like to pass over to Janet.
And I'm going to throw directly to Arnie Carey just to give us a couple of minutes wrap up before we close. So thank you everyone for holding on.
Thank you. I won't take long, and I won't wrap up each session because I'm sure that you've been paying close attention and have taken the names down of the people that you want to contact. But I just want to thank you all for attending the seminar, especially the researchers with their generous sharing of so many different and interesting topics, for the chairs for their management skills, for the organisers of this seminar, especially the ones at 3, and more especially for Laurel, who can obviously herd cats now. I feel as though I've been to an intellectual gustation. I acknowledge the strength-based approach of the diversity of research that's occurring in here and around our space, and the generous listening of the participants fills me with hope that no small amount of pride for the work that Western Sydney University is doing in our space. To be honest, to have a discourse such as this requires champions of cultural courage, and these champions are people like Professor Hennessy, Professor Pers, and Auntie Fiona as well. We have a lot of faculty members across our cluster who have really adopted cultural proficiency, have addressed their unconscious biases, and do us proud whenever they go anywhere. So on behalf of the team, we thank you for attending, and we look forward to working with you in future. So in the Cadigal language of my mother and her mothers, Welama, be safe and come back soon. Thank you.
Walama, Auntie Carey. Thank you, everybody.
Thank you.
Thanks all. Bye-bye.
Bye, Chris Purple Hair.
Keep a look in the 3E News next week. There'll be a link to the presentation, all the slides and videos. Thanks, everyone.
And I've been drip feeding Professor Trudgett, who can't wait to hear about it all as well. So fantastic. Okay. Thanks, Jeanette.
Bye, everyone.
Thanks, Auntie Carey. Thanks, Robbie.
How do we get out of here?